Hello Thrive Nation, we've got Dr. Alkesh Magan with us. He's an endocrinologist. We've been working very closely together for many years. It's a privilege to have you on the show.
Thank you, Steve, for the invitation.
Brilliant. I just want to tap you of everything, so hopefully we can take about 50 minutes just to really get a lot of your knowledge out to the listeners. We're now 49% in Africa and 29% in the US, so
Wow.
It's growing
That's
nicely
impressive.
and it's been a good journey. But you're an endocrinologist. You've been in practice for how many years now?
Well, in this area, just over a decade, in clinical practice for about twice that time.
Wow, 20 years. So you
Yeah.
must have seen things change. But
Well, I think that's true for anything in life, Stephen. Change is necessary because we're trying to work on therapeutics where we haven't designed the actual structure that we're trying to fix. So,
yeah,
our understanding is starting to evolve, and I think it's healthy.
okay. Tell us what your major concerns are with regards to physical or psychological health that you've seen emerge over probably the last 5 years that is really being alarming to you.
So a lot of the sort of concerns that we have around that stem from people that follow standard of care, that see their sort of general practitioners get referred up to psychiatrists, and typically start standard of care with very little symptom control or even with very little positive outcome.
Yes.
And often these patients land up by default, specifically because there's this desperate need to get answers to questions that typically standard of care doesn't really offer. So most patients that are typically unhappy or have problems with fatigue often land up being medicated with antidepressants, anxiolytic medications, sleeping tablets, or stimulant-based drugs to improve cognitive function. Now, whilst there are certain sort of parameters that would require this kind of intervention, by and large, we're seeing an epidemic of this kind of pathology now. And as we were just discussing earlier, this is certainly not something that's suddenly materialized in the human body for no reason. So I think, again, we all have to acquiesce to the fact that we are all products of our own environment. And typically, these kind of problems start emerging when there's a rapid or maladaptive change to our own environment. So I think a lot of these questions typically have difficult answers because the kind of commitment you need to improve them requires patience and consistency. Right? And in a world where we're interested in symptom control and rapid gratification, this is not something that most people typically will appreciate unless they've tried the standard of care, failed, and now are desperate for a solution.
So what you're saying, if they've got enough pain, or they've got a serious enough condition, or they're really sick, or they don't want to suffer, they might look at alternatives. If they're not like that, then that sort of seed of suffering is not strong enough for them to actually make these changes that we need them to.
Correct. And the other side of this equation is that people often land up at your door or my door when they've tried everything else that is sort of available on the market and nothing changes.
Yeah, I'm with you. So from an endocrinology point of view, or doing blood tests, or doing a full spectrum of bloods, we'll talk about functional medicine, and maybe you want to sort of define that, what that means to you. We had Jeffrey Bland, who's sort of the father of functional medicine, on the show. But possibly people are listening and saying, should my 12-year-old get a full set of blood tests and see an endocrinologist? I know there's not a lot of endocrinologists in this country, and you guys are packed. We had your good friend Dr. Sandeep Ruda on, and we've had Dr. Sandeep Bana on, and you guys just seem so busy. But maybe define functional medicine firstly, and secondly, when should people start doing some blood tests?
So I think the concept of functional medicine stems from our own definition of health. So the historical paradigm for defining health has been the absence of a disease. So if you don't have lupus, you don't have hypertension, you don't have rheumatoid arthritis, you don't have diabetes, and if you don't have a definable disease, by default you land up in the healthy category. You're healthy because you don't have a disease. And I think this is what's created this typically frustrating paradigm of people seeking answers and not getting sort of them answered, because our conceptual idea behind defining health, I think, needs to change. So we don't really define health as the absence of a disease anymore, but by the presence of well-being. So if you wake up in the morning, you feel like you've had enough sleep, you have enough energy and focus to get through your day, and there is no discomfort in doing so, and this is something you can sustain, by default you are healthy. When you have these non-specific symptoms that don't typically follow a diagnostic criteria or a classification, then by default there is no well-being there. This is where the realm of functional medicine was initially sort of coined, is can we look at optimizing your function to make you more functional at what you do? So this is where I see things. The idea is to try and optimize function, not try and exclude a disease. So where we see functional hormone manipulation is basically on that paradigm. Now, I often tell patients, if you've got high blood pressure, the doctor will tell you, well, if your blood pressure is below this reading, you don't have high blood pressure. And if you have a reading that's above this, you magically now have hypertension. And we have to do something about it, whether it's lifestyle, whether it's medicine, or a combination of both. The difference when you're trying to optimize hormone physiology is that there is one fundamental limitation behind the tool you have to optimally understand what happens with the hormone itself. Because we send patients for blood tests, and what does a blood test tell you? A blood test tells you about the circulating level of a hormone in your bloodstream. Because it's convenient, we can stick a needle into a vein and measure a level. But a hormone, if you think about it logically, actually works like a key. A key goes into a lock, the lock opens, the door then opens and something happens inside the DNA of that cell. But we're really not measuring what happens with the lock mechanism on the door. So whilst the difference between diabetes and hypertension is defined as a single number of normality, you will see what defines the reference range for hormone physiology is a range. It's normal from here to here. Now, conceptually, that is because some people have more locks on the door, they need less key. Other people have less locks on the door, and they need more key. The second problem we have is that if you were genuinely experiencing well-being, you would not seek any medical advice. I mean, when have you ever had a patient that says, I feel fabulous, I need proof of that? No, right? The only time someone actually comes to you is when they're not well. And the only time where you will send an individual for a test is where you're concerned about the fact that they're not well. So if we look at the reference range for normality, this is effectively driven by a population base that is not well. These are the people that go for tests. These are how we have our standard Gaussian distributions that define normal. Yeah. People that are not well, that seek medical advice, the medical practitioner then takes that further and does a test. So you, in essence, have a range of normality from a population that's essentially not normal. So again, this is obviously difficult because we don't really go around forcing healthy people to do blood tests. But often one has to read between the lines here. So this is why we make the distinction between the science of medicine and the art of medicine. The science speaks for itself. You have a randomized placebo-controlled trial, and it basically proves an intervention beyond the effect of placebo. And then I often tell my patients, okay, so you're using this medicine, it's better than a placebo. But bear in mind, the placebo also had an effect. So what drives your well-being doesn't necessarily require a pharmacological intervention. Because if your head is in the right space, you can actually help to heal the body from the inside out. Because every doctor then has to acquiesce to the fact that placebo does help when you're doing a clinical study. So you use that as the reference for a benchmark to justify the use of an allopathic drug. But we conveniently ignore the fact that it has a therapeutic effect by itself. So when we talk about organ-specific specialities, like endocrinology, for example, we're obsessed about hormone physiology. This is what we study to do, and this is what we understand. But if you look at the time that we get exposed to at both an undergraduate and a postgraduate level about talking about holistic health, it is almost non-existent. So we avoid the topic because we're completely inept at understanding it. Not necessarily because we don't believe that that is true. Doctors are creatures of habit. If we are comfortable with what we know, we'll ignore what we're not comfortable to discuss. So I've always then asked myself, if I treat a patient and I have a result that suggests that my therapy is working, and feedback from my patient that suggests the contrary, well, I've taken this medicine, I understand the test looks good, but I feel rotten.
Yeah.
This then leads you to ask difficult questions about the limitation of your own knowledge. So if we talk about testing from that perspective, I'm not a big advocate for saying, well, every 12-year-old at this stage needs to have a blood panel done to see what's happening with the proactive physiology of life. We talk about the historical trajectory of that individual. So if you have a toddler that was completely functional, became sort of a teenager that was completely functional, and then suddenly became dysfunctional, then this is an individual who has something that is abrupt, that is aberrant, that needs intervention. If you have an individual that's completely asymptomatic, that is functional, that is sleeping well, that is performing well intellectually, then by definition there would be no need to intervene in that area. So with the ubiquitous access to information, that's the other thing. It's like drinking water from a fire hydrant, right? It's very difficult to limit what you can understand, because we have patients that typically do a whole barrage of tests because they are concerned about their health. And with the access of DNA testing now being readily available, everyone has pretty much every single SNP test that could possibly be commercially available tested. And they say, well, I'm really concerned because I have this, and this. And according to what this report says, I'm going to die tomorrow. And then you sit down and you say, well, look, if you didn't have access to this and you are completely asymptomatic, then would it have really made a difference to your life? No, you would have been blissfully unaware that you carry A, B, and C mutation. And the other thing that also supports this kind of thinking is if we take people that are identical twins, so they've got exactly the same DNA, you'll see that in some instances, the one twin gets a genetically inherited disease, but the other one doesn't. Now, they have exactly the same DNA, don't they? So what then determines the difference between the two? And I think this is the more important question we need to answer. What is the impact of our environment? These are the things that typically express how we choose to express the DNA mutations we have.
Absolutely. And do you think a lot of the research now, experienced practitioners I've had on the show have said it's 90% environment and 10% genetic?
Yes.
Or what would you say?
Yes, I think that is perhaps would be universally true, right? Because if you look at, well, if you believe in Charles Darwin's theory of evolution, then bear in mind that an evolutionary adaptation that would provide a positive or negative survival outcome would be something that evolves over millennia. If we look at the burden of non-communicable disease, cardiovascular disease, psychiatric disease, fibromyalgia, chronic fatigue syndrome, we've seen an epidemic in the last 80 years. There is no way for the human genome to adapt that rapidly. The only change is environment. Now, perhaps the model of study that we typically appreciate is in those very small pockets of populations that have been relatively immune to a change in environment, a change in industrialization, a change in urbanization. And we see that these pockets of individuals typically in their native dialects don't have words for psychiatrist, depression, night sweat, hot flush, brain fog, because they don't have any of those symptoms. So when we analyze, because we map the human genome, it's no longer this mystery. We know exactly what the human genome comprises of. When they looked at these individuals, what was so fascinating was that they didn't have anything magic in the DNA. It was pretty much what we would have expected. The only difference is the environment. So we take individuals that enjoy a good life expectancy, for example, right? Those were effectively analyzed. Rural Sardinians, rural Japanese, non-urbanized Australian Aborigines. There was nothing magic about their DNA. What was the ubiquitous truth is that the environment was consistent.
And that's important, and I think we're going to need to sort of labour that point that environment and lifestyle is crucially important for the manifestation or epigenetic manifestation of the genes, meaning above. But my concern is, and that's why I want to get your perspective on living in the city, we've got certain environmental factors. When do we start testing things like vitamin D? You know, I did my first lecture on vitamin D that I gave in 2001 about the importance of vitamin D. Now you're looking at people, young people. I saw a young lady yesterday, she was 15 years old with immense hormonal dysfunction, exceptionally painful periods, had real issues hormonally, and her vitamin D was like 11 ng per ml. So here we've got a significant problem here because of lifestyle. Now that possibly could have been avoided if the kids were outside and they were rural and they were living with correct lifestyles, but they're not. They're indoors. Now I'm giving my daughter, she's 6 years old. When do I start doing the blood test? I'm giving her 1,000 IUs a day, trusting that that's enough. I'm not sure if it is or isn't. Making sure she gets the magnesium, which is crucially important. You know, pouring a little bit of vitamin K2 in her mints now and then. You know, these little things that I've learned without sort of pathologizing a 6-year-old that is very functional, has got lots of energy, but I know over years with a low vitamin D or a low ferritin or a lot of low things or maybe high things, obviously there's balance, could crucially determine a lot of her development.
Yeah, so I think, again, that speaks to the fact that not everything that is necessarily sort of fat soluble is something that would be replete with, right? So you talked about vitamin D. Now, we technically call it a vitamin because it has antioxidant ability. There's a reason why you make it in the skin, is because it literally protects you from the ionizing, cancer-causing ultraviolet radiation you produce. Now, from that perspective, these don't really, so your A, D, E, and Ks of the world are not technically vitamins, they are prohormones. So they regulate, as you have suggested, they regulate a whole lot of different processes which help an individual to function. And we have some data in first world countries where proactive screening was effectively done. And the recommendation here was to fortify foods and milk with these substances to reduce the epidemic of deficiency. Because if we were then to do this as a sort of guideline for the whole country, how do you rationalize, well, who gets to test a vitamin D and who doesn't? From that perspective, even in a completely asymptomatic sort of scenario, as you have suggested. So often difficult by virtue of the fact that our food is getting more and more processed. The nutritional value, as opposed to the caloric value of our food, is actually starting to drop. So where we have perhaps some guidance here, specifically for third world countries like sub-Saharan Africa, is when your child is born, you normally get that road to health chart, that vaccination card that effectively plots a child's head circumference, a child's weight, a child's height. And there's a reason why that is done, is because typically when there are these nutritional deficiencies, what you see is subtle changes in the growth velocity. So not necessarily the fact that the growth tapers off, it doesn't follow the same trajectory. So when this is a nice cost-effective way of seeing, well, these are people that perhaps we may need to proactively screen, because what was now tracking beautifully has suddenly started to drop off.
So maybe it's about trends and tracking.
Correct. Right? So it's about monitoring this through more than one data point.
But which parents are going to be able to do that, or which organizations are going to facilitate
Well,
that?
this is the thing. If you ask any parent that is responsible, where's your child's vaccination card? Often, Stephen, they'll be able to have that because you need that to travel. It's just the fact that we're too lazy to take our own kids and say, right, jump on the scale, just stand next to the door, let's just see how tall you are.
Because you want the trend of what's happening.
Correct. You want the trend of what's happening. So that's a simple test, but it takes time.
Okay. So with regards to testing, what you're saying, if you're not symptomatic, then don't do the testing. Although I've seen so much precocious puberty like never before. I think it's got to do that with sleep and devices that, melatonin inhibits, I think there's some studies, inhibits these sex hormones. And so with a drop of melatonin early causing possible problems, now we've got people with precocious puberty, early onset, we've got hormonal dysregulation. My concern is I'm just seeing more and more people that are younger and younger.
Right.
And the lifestyles, unfortunately, that we are saying, get outside, get into the soil, have good friends, go on holidays, limit devices. Well, these kids are not limiting devices.
Right. But again, this would be an example of something that is not normal. A child who enters puberty precociously, by definition, would not be normal. This is an individual you'd be concerned about. This is an individual that you want to proactively manage. Besides just what happens with melatonin suppression and blue light and the fabulous benefits of technology, what we've also seen is the amount of synthetic xenoestrogen in our environment has increased exponentially. Right? That's not just with the injudicious use of contraceptive medicine. Synthetic xenoestrogens, like what we get in phthalates, typically in terms of water bottles, those kind of things, these are commonplace in a city from that perspective. So again, the awareness here is to try and limit your exposure, because trying to rescue that by offering some kind of intervention long term is a much less sustainable option. We all live in the real world, and you limit what you can, and whatever you can't, that is creating a symptom, you have to proactively investigate and manage.
Okay, brilliant. So the 7 pillars of Made to Thrive are purpose, being very important, community, your social ties, your social integration, your environment, talking about radiation from cell phones, non-native electromagnetic radiation, light, things like quality of air, quality of water, nutrition, sleep, movement, and the last being self-quantification, to become aware subjectively, and not only objectively with all the wearables, which I think have a role, but to be subjectively aware and be mindful of the moment, which is really, really important. I think people are just not stopping, not pausing, lacking mindfulness. But if we have to look at those sort of 7 pillars, take us through how important it is if you've got someone who's sort of growing up and developing, when you would test them. I mean, if I can press you, I know it's dependent on each, but I want someone who's listening there to say, hang on, these are major symptoms that we need to look, and these are the things we want to prevent. Like vitamin D can be low for many years. The damage it does over a 10-year period of being low is like significant. And now you've got to try and reverse that because you've had a low vitamin D. So give us a sort of like the big things that you focus on with your patients. I mean, because I think nutrition is a huge important lever, but people say, yeah, it's so simple to change your diet. And it is, but it's the hardest thing to do. It might be the lowest hanging fruit, but it's the hardest fruit to pull off the tree and sustainably pull it off the tree. As you know, people come in, they're sick, they change their diets for 6 months, 9 months, a year later they're back to their old ways. So give us a sort of a framework on how you would think about people growing up.
You see, what the studies have perhaps suggested is that these kind of things, when they're emphasized in the first 3 years of life, typically are much more sustainable after that time. So children imprint these habits in terms of their environment, and the best bang you get for your buck is within the first 3 years. Wow. So in individuals that are from dysfunctional families, from families that have these kind of habits, because you and I both agree the chances of them instilling good habits in their own children are going to be significantly less. These are the children that you typically be worried about. And this stems from issues with cognitive development, from development of motor skills, from development in terms of what happens with sleep, in terms of what happens with their ability to process information. So I think these are useful clues that will then alert you to the fact that, hold on a second, if my child is in a class with 12 other children, he is not learning at the same rate. He is always tired. He is typically putting on a midsection whoop, which shouldn't be happening at this stage. Right? If he's complaining that his muscles are cramping for no reason. Right? So non-specific muscle cramp is perhaps one of the most simple symptoms of vitamin D deficiency. Now, vitamin D is very famous for its ability to sort of optimize what happens with calcium homeostasis in the body. But what is also critically important with vitamin D is that it is what we call a phosphatonin. It has the ability to regulate phosphate in the human body. Now, again, something I tell all my patients, well, if you are concerned about a mineral deficiency, you would go to a pharmacy and say, well, listen, I'm getting cramping. So the pharmacist says, well, maybe your magnesium is low, take some magnesium. And then, we have a calcium supplement, and then we've got a potassium supplement. And I tell my patients, have you ever seen a phosphate supplement on a pharmacy shelf? Almost never. And the reason for that is because we've got tons of phosphate in our food. So even if you had this sort of fast food munching child that was not interested in eating whole food, there's still more than enough phosphate in a child's diet. It is vitamin D that effectively keeps it out of the urine. So at the sort of fundamental level, our ability to store energy at a chemical level is based on a substance called ATP, and adenosine triphosphate. It is the vitamin D that effectively keeps the phosphate out of your urine. So something simple, like a child that says, well, I haven't played anything, I have muscle cramping, it's sore. And what do we typically call that? No, you've got growing pains. This is the reason why. Right? This is just because you're growing too quickly, you're stretching the epiphyses of your growth plate. This is the reason why you have pain. The sad reality is these are the typical symptoms of vitamin D deficiency. So it's the not so obvious things that we typically push aside and say, yes, we all had this. You grow out of it eventually. Right?
But the damage that is caused sometimes is significant.
Yes. So this is why it pays to listen to your child. Because when there are symptoms that are more progressive or out of keeping, these are the things that typically alert you to the fact, hold on a second, this is not my child. There is something wrong here.
Okay, brilliant. Right? I want to sort of round up on children, but little Zoe, I've got an 18-year-old and I've got a 6-year-old, and we look at vitamin D with her, and we look at EPA, DHA, the omega-3s. Those are the two that we are trying to supplement with her. What are the things that people can look at that you see hugely deficient? I mean, I know how important vitamin your omegas are. I do the Xeno test. I haven't had a single person here who's tested with high enough omega-3s, no EPA, DHA. I'm talking about minus 80% off the deviations, minus 70 off the deviations. I mean, DHA is so important for neural function. If you miss this window, it's really, really important. So tell us about, sort of to round us off with children. People are listening now. What should they be supplementing?
So obviously the vitamin D is important by virtue of the fact that a lot of the food is processed. And the thing is, for the sort of fussy eater that's not really interested in eating whole foods, omega-3 supplementation is incredibly important. Now, what we generally try and sort of encourage in children is to look at more plant-based omega-3. So things like your avocado, your sort of tree nuts, those kind of things. I'm typically a lot more cautious about using medium-chain triglyceride-based omega-3 in children. Not to say that it's dangerous or anything like that. It's just the fact that bioavailability for plant-based omega-3 is generally very, very good. And in individual, again, where there are dietary allergies, those kind of things, then as you have correctly pointed out, I've yet to have someone that has got a completely repeat nutritional panel. That is a universal truth, not even just for children, even for most of the adults that we actually treat. So one then needs to ask, is there a downside to omega-3 supplementation for everyone? Is that something we can universally then just advocate because it's so common? The only thing with omega-3 is the fact that at high doses it has the same blood thinning effect as a baby aspirin. So it has antiplatelet function. So the only time we're more concerned about this is in individuals that have some kind of genetic bleeding diathesis,
Yeah.
or in a child that's on prophylactic anticoagulant therapy. Because we often warn parents, omega-3 is good for brain function, but if there's a dentist visit and you're going to expect a root canal and your child's on a blood thinning drug, you should actually stop the omega-3 before that. So in the very rare circumstance, these are specific considerations that we advise and warn patients on with reference to the use of omega-3. But I agree with you. I've yet to find someone who died from omega-3 overdose, quite frankly.
Comment round up to children in terms of vitamin D, because that is a real concern for me, because I've never seen vitamin D levels drop. I started doing functional medicine 13 years ago. The range was 30 mgs per ml to 100. When I did my functional medicine training, we kept it between 60, 70 mgs per ml. Things have changed now. This osteoporotic literature coming through now. So tell me, firstly, what level you're generally looking at, and then secondly, the supplementation of vitamin D, especially with children, because I think it's so important for bone and development.
Right. So if you look at sort of the South African Menopausal Guidelines Society recommendations in terms of what we have, I must say that recommendation seems to be very, very conservative. And they say, well, a vitamin D level above 20 nanograms per ml is theoretically sufficient for bone homeostasis. Now, again, this is all dependent on how you view vitamin D. Because if this is purely the calciomimetic action of vitamin D, then yes, we don't see an elevation in parathyroid hormone when vitamin D levels are above 20 nanograms per ml, and hence physiologically the recommendation for that. If you understand everything about what vitamin D does beyond calcium mimetics, then you start expanding the definition, and this stems from a lot of the work done by Michael Hollick in the sort of US on vitamin D. So my personal preference is to keep the level above 50 nanograms per ml.
50.
Right, 50. And where there's a compelling indication to go higher, where we're not necessarily worried about hypercalciuria or the formation of kidney stones, then I would push that a lot higher. So in children with childhood sort of blastic cancers and leukemia, we target the levels between 70 and 100 nanograms per ml. In a child with autism, I'll target a level above 100, between 100 and 140 nanograms per ml. Because we've seen some emerging data there that it actually improves what happens with their cognitive scores. So again, the sort of gambit for vitamin D is based on the clinical scenario in which you find the patient in. So if there's a compelling indication to use a higher dose, I certainly would not be hesitant to do so. So the recommendation here from specific labs is that if you have a level of more than 60 nanograms per ml, it's technically defined as vitamin D toxicity. And every doctor who reads that reference range gets in an absolute panic because, oh, well, you're overdosing on vitamin D and you're going to drop dead because this is the nasty effects of vitamin D. Now, it's interesting. They did a study in Hawaiian lifeguards. And we know for a fact that this population doesn't really bother about the fact that the vitamin D is low or concerned about vitamin D supplementation. And if you look at subgroups of that population, you'll find levels that are above 140 nanograms per ml, comfortably. And when you look at this population database, we don't certainly see the nasty kind of vitamin D intoxication that the medical literature talks about. So in individuals specifically that have concerns about hypercalciuria, you got a patient that has had recurrent renal calculi, you're going to be much more conservative with the kind of vitamin D replacement that you get. What now makes the topic even more complicated is the fact that based on the fact that we now have genome sequencing, we now know that there's a huge cohort of patients who have vitamin D receptor knockouts. So again, it speaks to the lock and key type of principle. Because at the receptor level, vitamin D has very little activity in those individuals. So we often find these patients coming referred by sort of general practitioners say, look, this patient's probably got a parathyroid neoplasm sitting behind the thyroid because the level is high and the vitamin D is above 20 according to what the laboratory says. There shouldn't be a high parathyroid from a low vitamin D. And I'll show you many examples of patients where we've just optimized this and it drops beautifully.
Sure.
When we sequence these individuals, you'll find that they have high impact mutations for a vitamin D receptor knockout. So the evolution of understanding behind what your body does to a vitamin, I think is important, not just how much of a vitamin you have, because we can quantify vitamin D3, we can quantify vitamin D2, and the recommendations are based on what we can quantify. How well that works, we have no recommendation for, because we didn't have the tools or the armamentarium to evaluate that. That's starting to change. Right? The same example can be made in individuals who have methylation defects. Right? Often you'll find these patients taking all sorts of vitamins because they feel absolutely smashed and knackered. They go to their local doctor and they say, you know, I feel smashed. He says, well, you're taking all these vitamins, let's just check what your levels are. And the vitamin B12 comes back sky high and he says, well, you're overdosing, but I still feel tired. Why? Because the reality here is the fact that although you can absorb a vitamin, doesn't necessarily mean you can activate it or methylate it. So this kind of concept is starting to gain credence. Even with progressive psychiatrists even, this is now being looked at because these are people that are more refractory to the typical standard of care, the anxiolytic, the antidepressant, right? Because I'm sure you've also seen every second child is on some sort of dopaminergic agent for this magic epidemic of attention deficit hyperactivity disorder that we're seeing. Right?
Absolutely.
But again, what does that speak to? It speaks to problems with environment.
100%.
So we can optimize what we can nutritionally to provide support for individuals who are symptomatic. At the end of the day, is that really going to solve why we have the issue? No. Is it a practical interim measure while we're trying to find a more intelligent solution? Yes.
Brilliant. So that's omega-3s. Vitamin D, you don't have a recommendation on international units for children that parent can just sort of safely take?
Yeah, I think the sort of recommendation for children stems from a very conservative dose, 400 international units. And this was a study basically done to minimize the occurrence of rickets and osteomalacia. This is where we come with a 400 IU recommended daily allowance. There's no real science behind what we recommend. The recommendation, again, stems from that archaic concept of health. If you don't get 400 units of vitamin D in your diet, you get rickets.
I got you. Okay, so let's go to people's black skin, because something I've noticed significantly, the darker your skin was an evolutionary process because you had a lot of UV. So you've got melanocytes, you get darker, you've got dark hair, you've got dark eyes. So the black population, or people with dark skin, I've got Greek sort of olive skin, we need to spend more time outside to get that vitamin D. Where your light blonde hair, blue eyes, who comes to Africa, probably doesn't have to get outside that much because he's getting good levels of sun and sort of your... So comment on that, because seeing more of African population here, I've seen some of the worst levels when it comes to that.
Yes, so the fascinating dichotomy we have in Africa, though, is that although we have an epidemic of vitamin D deficiency in our African population, for the kind of vitamin D deficiency we're seeing, we see very little brittle bone disease, right? So if you think about the conceptual paradigm of vitamin D, just in terms of its effect on bone and its trophic effects, what we see in the African population certainly is much less osteoporosis and low impact fractures historically. Is that changing? Yes. And the reason why it is changing is because we're seeing an epidemic of obesity. So remember that vitamin D is a fat-soluble vitamin. If your body fat percentage increases, the serum level is going to drop. And we know that obesity is a pro-inflammatory disease. So beyond just what happens with vitamin D, the pro-inflammatory nature of obesity accelerates bone turnover. So you're quite right. It's not just the darker your skin is, the bigger your body is, the more vitamin D you're going to need, right? Because it is a fat-soluble substance.
Sure.
So I think, again, Africa is starting to change. And the conspiracy theorist in me will basically then say, well, this is a population that was typically impacted by the burden of infectious disease. HIV, tuberculosis, malaria, these are the things that kill people in Africa. If you look at data now, in the next 40 years, we are going to be at the epicenter of a diabetes pandemic, right? Again, a population that was relatively immune from getting a non-communicable disease is now suddenly at the epicenter of a pandemic. In a space of 40 years, what is changing? Urbanization. So we're going to get more insight to what happens in Africa with time, because the landscape of Africa is starting to change. It's quite dynamic at the moment. And what is typically written when I was studying in textbooks, certainly not going to be true in the next sort of 10 to 15 years.
Good. Let's carry on with testing. I think you've spoken a lot on blood tests. What other tests do you look at? Do you do food intolerances? I've discovered the amino acid testing. People are taking bucket loads of collagen, I don't know, filled with proline and filled with glycine. I think it has a problem with the other amino acids because people think a little bit and have more, and they just, the patients that sort of we see. What other testing are you looking at? Are you doing heavy metal testing? Are you doing hair tissue mineral analysis? What is part of your armory?
So in terms of looking at where the subtle clues for disease are, I think, Stephen, you've hit the nail absolutely on the head there. So amino acid profiling is important because, like anything in life, everybody believes if this thing works, then 10 times the dose would be 10 times as effective, right? So that's the typical misconception that we see. Hair mineral analysis we typically like, specifically for heavy metals, because trichology, I believe, would be the gold standard in terms of evaluating what your exposure is to metals, right? Because that gives you a historical timeline from that perspective. So these are often useful. Now, the issue of proline-rich substances, specifically when it comes to what happens with food intolerances, I think is becoming more topical, as we've seen in a lot of the literature coming through. And it again speaks to the fact that we understand that for most individuals, the ability to convert glutamine into proline is generally very good when you're young. So often the kind of benefits that you get from collagen supplementation at that age is going to be minuscule. When you age and you have other issues, inflammatory bowel disease or malabsorptive syndromes, then certainly there is some emerging role for the use of hydrolyzed peptide collagen, because we do know that the ability to make proline from glutamine does deteriorate as we age. So again, one sees a study and they think, well, okay, if it's worked for him, it's got to work for everyone, and this should be the ubiquitous truth. We all should be supplementing all 10 types of collagen, right? It's the same when vitamin K was initially sort of introduced. Well, vitamin K1 causes clotting, so all vitamin K is then evil, because if you take any vitamin K, you're going to die from a blood clot, right? It's only when we understood the role of vitamin K2 from MK1 to MK10 that we realized, hold on a second, this has got nothing to do with clotting. This has got to do with the delivery of calcium to bone and why that is important. Now, again, that also speaks to what we talk about as degenerative versus deficiency. So we typically talk about arteries narrowing as you get older, arteries hardening as you get older. And this was thought of as a degenerative or sclerotic process. What does emerging research tell us? We're actually finding remnants of bone in the artery wall. So this is not sclerosis of the artery, this is ossification of the artery. So lots of controversy in the US specifically with regards to vitamin K2 and the fact that if this was done responsibly, we could reduce the need for aortic valve replacements and aortic aneurysm repair significantly, right? But is there a vested interest to do that when there is no patented pharmacology that can benefit from an intervention like that? No. So again, you need to ask yourself, is there a hidden agenda behind keeping you ignorant? So I'm of the opinion from that perspective, when you have the need for looking at something specific and supportive, use it and monitor its efficacy, right? When you start extrapolating benefit from a small study is where you're going to start running into trouble. Now, we understand that a lot of the stuff that's typically gray, that doesn't fall into an autoimmune disease, this basically gets dumped into the fibromyalgia category. Well, you have fibromyalgia. It's a nice label to have, but what does it mean? It means nothing, right? And we're typically now seeing that sort of the gut health connection is certainly becoming a lot more evident because we now have a more scientifically validated paradigm to evaluate those kind of things. So food intolerances specifically speak to a whole variety of things that we have in our diet. But again, this stems from having problems innately with gut health. So for individuals that have specific problems with intolerances, so we talk about patients that are exquisitely sensitive to lectins in foods, right, for example. These are things that we test for because often they'll go from doctor to doctor, have scope after scope and say, well, you've got non-specific colitis, so you've got irritable bowel syndrome. And you just take stuff to help with your symptoms. You take an antidiarrheal when you have diarrhea. You take a laxative when you get constipated. You'll take an antispasmodic when you get cramping. And you'll take an acid blocker when you get reflux.
It's true. It's
right?
true.
So this is standard of care. And again, it's something I ask my patients. I said, well, you chew your food, right? Yes, fine. So you are mechanically breaking down what you put into your mouth. So what happens in your stomach? No, I produce stomach acid. I'm like, okay, so what's the purpose of stomach acid then? Well, you are chemically digesting what you've mechanically chewed, haven't you? Okay. So once that has happened and your stomach now empties into your digestive tract, you don't really digest anything. You absorb nutrients. So we understand that gastric acid is not supposed to be in your esophagus. It is a potential carcinogen. And in individuals with mechanical structural defects, I'm afraid a drug like this is a necessary evil. But I'm sure you've seen and I've seen patients that get these things thrown like Smarties. Oh, you have a bit of tummy upset, it has to be reflux. Here, take this for 6 months and I think you'll be fine. What do you see 4 months down the line? I'm tired all the time. My hair's falling out. I can't remember what I need to do. I think you're just depressed. You just need a good antidepressant. Right? You'll sort of have a look at that patient. You'll find epidemic magnesium deficiency from the proton pump inhibitor. You'll find vitamin B12 deficiency from the proton pump inhibitor. But we are very quick to prescribe the drug. We don't actually educate our patients in saying, there is a price you will pay for this privilege.
That's true, and I think so. You look at amino acid testing, hair tissue mineral analysis. You may do food intolerances, especially because of lectins. We had Dr. Stephen Gundry on the show talk about his lectin-free diet. Incredible episode. We'll put a link to that show. So those are the testings you do. What other testing do you think is important? Someone's listening.
So if you're going to look at trying to optimize what happens holistically, then what we effectively look at is basic hormone physiology testing, right? So we look at cortisol day curves in individuals, we look at melatonin day curves in individuals, and when you have teenagers that have started adrenarche, where the adrenal gland has started to work, then we look at sort of adrenal metabolite analysis in these types of individuals, right? Again, there would be a specific instance in terms of where you would look at that, right? So an individual who suddenly now develops a personality disorder, or an individual who's now labeled with chronic fatigue syndrome. And now more important, a lot of the patients I'm sure that you've seen with long COVID, for example, right? We've seen huge problems with adrenal reserve in those individuals.
That's true. Measuring sleep, Dr. Magan, using sort of these devices that are not really accurate according to the sleep studies, but they're precise, meaning making the same errors and giving you a trend, which I think is important.
Yes.
That's important from a wearable perspective, I think, and also because the cohort is so big. So now people are saying, well, do I need 2 hours of REM sleep and 2 hours of deep sleep? Yes, but actually you're an individual. You actually need to trend and track it. So when I go to Cyprus with my family, I see what my numbers are. I see they're 30% better than when I'm in Joburg. That's my trend, and that's where I need to go. I'm obviously relaxed, I'm not working, I'm outside, I'm in the soil, I'm eating good food, I'm with good company, my numbers improve. So number one, your view on sleep testing, and then secondly, a big thing that I think is crucially important that has helped a lot of my patients and clients is CGM, continuous glucose monitoring. So comment on those two.
I think if we're going to really answer the issue of sleep testing, I think we first need to start with what we understand by sleep hygiene, right? Because there's no point trying to test what happens with your REM sleep or non-REM sleep if your commitment to decent sleep hygiene is not consistent. Because all you're going to do is just document the neglect. You're not actually going to fix anything there. So I think the advice that we typically give most of our patients when we start is make sure that your room is cool, dark, quiet. Anything that emits blue light for at least 90 minutes before you're planning to go to bed, you need to eliminate. Anything that is potentially stimulant, you need to eliminate. Once you've done that correctly, then have a look at what happens with your symptom control first. If you're still waking up smashed in the morning, then it's definitely a good idea to start monitoring what happens with the depth and quality of your sleep. And this doesn't just stem with what happens with REM and non-REM sleep. What we've also found is that this has been a good opportunity to pick up those subtle issues with regards to patients who have sleep apnea, for example. Right? And I'll show you a whole lot of people that don't fit the typical textbook for sleep apnea. Right? They don't have a short mandible. They've got a long neck. They're not obese. And they have profound sleep apnea.
Wow.
So often, again, we look at adrenal reserve testing and we say, well, your sort of morning cortisol response is actually inappropriate and you're feeling tired all the time. This must be an adrenal issue. But the truth there stems from the fact that what you're not doing for 33% of your life is probably the reason why you have the problem to begin with. So I'm much more hesitant to just throw adaptogen kind of supportive therapy unless I understand exactly what's happening with sleep.
Good. HRV and measuring heart rate variability.
Yeah, I think that's perhaps a very useful tool in terms of answering that in a non-invasive manner, right? Because I think if we look at where the data is going, like with our understanding of glycation and what happens with sugar, HRV is going to be a very good surrogate marker to establish what happens with sleep mimetics.
Now, what I do with a lot of my patients is I actually do breath work with the HRV monitor, little sensor on their finger. I do the breath work, I do the mindfulness, and they see their HRV improve. They see the trend. They do a morning readiness test. They say, hang on, if I actually meditate and I do this breath work, things improve. Yeah. And then they start trending, then they start feeling better.
I think, Stephen, that's the one benefit of these devices is that they provide a visual incentive to improve compliance. Yeah. Right? Because if you say, well, we need to practice mindfulness and you need to make sure you actually use your lung and breathe properly, it sounds quite lame, doesn't it?
Yeah.
I mean, now he's telling me to breathe.
Yeah.
How is this actually going to help me? But when you find objective evidence of an effect that you can see, then it incentivizes you because you now have seen that it's actually not lame. It does something in the body.
Brilliant. Comment on CGM. We're coming to the end of the show. Continuous glucose monitoring, I think, is something that is such good feedback to my patients. They've changed their diets. They've changed the order of their food. And it's been sustainably changed when they've seen what happens to their glucose. Example, I used to do a green smoothie and my sugar used to skyrocket to 9. I added some eggs in there. I added a little bit of fat in there, and it actually was really only got up to about 6. So I didn't have these huge spikes of glucose, and it wasn't this huge spike and this crash down. How important do you think CGM and the democratization of CGM? We've got health coaches that work with our clients. Why? Because they want to understand the data. So it's not just giving someone a CGM and saying, hey, go on. They don't know how to use it. They don't know how to make the notes, the meals, the intermittent fasting. Give us your perspective on that.
I think, again, the tool in terms of evaluating what CGM really brought was initially to answer what the unmet need was in terms of managing diabetes per se, right? because the sort of armamentarium that we had in terms of evaluating how good your glucose control was didn't really correlate with the kind of protection you should have seen. So you have some individuals that start and you do a 3-month average sugar for diabetes and it's perfectly normal, and the guy's going blind in one eye, they've chopped off one foot and is now waiting for dialysis. And the doctor's really perplexed as to, well, it looks pretty good on paper. Why am I seeing this kind of target organ damage? This is where CGM first started making its sort of role. And the concept is really straightforward, is the non-enzymatic binding of sugar damages DNA and proteins, wherever you are on the planet, whichever part of the body you look at. So this is where the historical paradigm for CGM first started. Can we have a more accurate tool in someone who's overtly diabetic to reduce an outcome? Then the thinking was, well, hold on a second. You don't necessarily need to have diabetes to actually have a problem with glucose variability, because this is what CGM really answers. How do we reduce the violent variability of what we see in our bloodstream with what we eat, even though we don't satisfy the diagnostic criteria for diabetes? Which brings us back to the first point. How do you define health? Because according to a 3-month average, you're not diabetic. According to a CGM machine, you need to make serious changes in terms of your nutrition. And a lot of this stems from the fact that the spikes in glucose in a non-diabetic individual would mirror what happens with the spikes in insulin to control that glucose. So a lot of the symptomatic improvements that we've seen in terms of energy, concentration, motivation, fertility, are driven by what we've seen with the surrogate drops in insulin. So I believe the benefits of CGM offers us an insight non-invasively to establish what happens with insulin mimetics. Because I think this is going to be more topical. I think optimizing what happens with hyperinsulinemia is going to be the key benefit in terms of what CGM offers even in the non-diabetic space. And it allows us to now test the hypothesis of what advice we give our patients. Because a lot of the low glycemic index carbohydrates that we often push to our patients are particularly noxious in terms of what we've seen on CGM. So the nice thing about this is the fact that it's relatively low maintenance. Patients are much more proactive when they see physical data. So I think it's an exciting space. There's some very interesting work done now on CGM in the non-diabetic space, specifically for things like Alzheimer's, patients with multiple sclerosis, patients with heart failure. So we're seeing that no system in the body works in isolation. And this certainly seems to be a lot more relevant beyond what it was initially designed for. So yes, in a nutshell, CGM's, to my mind, is a very exciting technology.
And I think if people are listening there, they should really look at getting to a practitioner or someone like yourself or someone who knows a lot about CGM and have it 2 weeks. I mean, it's not that expensive. I think it's probably like, $1,500 right now. I'm not sure, maybe even a bit cheaper.
Yeah, it's the price has actually gone down subsequently. So yes, so this is what I'm saying. When you have a symptom that is basically you cannot get an answer for, and I tell, like I always tell my patients, common things occur commonly, and you look for common things. And then when you've excluded all the common things, you look for the uncommon manifestations of common things before you look for uncommon things.
Yeah, got you. Last question. We at Made to Thrive, this health optimization company that I have, used a lot of health coaches. Finding doctors are very, very busy. The average GP, I think, consult is about 12 minutes in South Africa, 7 minutes in the US. They're not equipped to help people sustain transformation, to make these changes. There are not enough doctors. There are not enough endocrinologists. We know that. You have a lot of your colleagues here. And it's just so difficult to get time, and there's just so many patients that you need to see. Give us your view on someone who's trained. I know there's no certification specifically for a health coach in this country, but in the US, and I've had some of my health coaches get trained in the US. what is your view on health coaching in the long term to meet the demand of people with regards to lifestyle and the epigenetic manifestations that we've spoken about?
I think if you look at the answer to that question, you can see perhaps the earliest sort of support of that. If you just look at, forget life coaching, even if you look at someone who helps as a straightforward dietitian, and we've seen some of the early data in diabetes, you can actually get a 2% reduction in the 3-month average sugar just by sending someone to a dietitian. Forget everything around what happens with nutrition. So again, I think because this is not invasive, it is goal directed, and it is continuously reassessed, it would be a no-brainer for me. Life coaching for the management of any non-communicable disease or any undefined pathology would be an absolute prerequisite. Because you make contact with that individual on a regular basis. If anything has changed, that individual is a lot more sensitive to those kind of changes, and corrective action can then be instituted. And as you've correctly pointed out, we don't have the resource allocation. I'd love to see every 3 weeks get a sort of heads up in terms of what's changed and what's different and what's new. I'd see you every 6 months. That window is way too long in terms of optimizing any kind of outcome.
So then let me ask you this question, because I've been to specialists. I told you I've had Dr. Golding on. I've had many specialists that I've been to in this city and abroad that don't refer to health coaches. And when I say health, people that have gone through either a year or significant period being trained. Some of them are nutritionists, some of them are dietitians, some of them have these certifications, but they're saying the specialists do not refer. Is it something of education to go to the endocrinology conference or to go to some type of conference to make people aware that, hang on, they're not going to say the opposite of what the specialist or the doctor's saying? Or do they need to spend time in the office with the specialist? How would you sort of recommend people that are listening? Because I've got a lot of health coaches that listen and say, well, hang on here, these endocrinologists and these specialists are so busy, but we're twiddling thumbs here because we're not getting referral. And if the doctor doesn't send the person, then people don't want to come.
So, Stephen, the good news from that perspective is that if you look at consensus guidelines and international recommendations for things that we would treat, there are now specific provisions for the inclusion of these services in terms of the management of a patient. So even if you have a very narrow-minded, allopathically driven, sort of paper result orientated specialist, that specialist still now has to read an updated document that says, hold on a second, you are one part of a team that now needs to look after this individual. So you won't necessarily need to try and optimize the awareness at a specialist level. These specialist organizations that bring out guidelines for the management of these conditions are now having to acquiesce to the fact that doctors by themselves are a useless option at obtaining an outcome.
Agreed, but how do they, so does a person go around and say, hang on, I've been doing health coaching, this is my qualification, because I know I'm going to get a lot of messages about this. Okay, Dr. Stavro or SteveStavs, how are we going to do this? How are we going to get to the specialist? How do we show them that actually we can help their patients along this journey?
So what would be a good platform perhaps to access specifically that kind of intellectual capital is to make the presence of these services much more obvious at specialist update meetings. Because often a specialist will tell you, listen, I have 12 reps that try and sell me the same crap every single day. I have this amount of work that I need to get through in a day. I really don't have time for your lecture in terms of what services you could possibly offer me.
Exactly.
Right? But I am forced to go to an update meeting because I need that to keep my license. Which means this becomes the perfect forum. One group can effectively talk to a whole body of specialists to say, well, this is where the research is going. This is not because we're recruiting business. This is because this is what the evidence tells us. We're just making you aware that the service is available. Please use it.
Brilliant. Thank you for your time.
You're
Is
very
there anything
welcome.
else you want to share with the audience or the viewers on YouTube regarding health or wellness? I've had more down days with regards to my profession in functional medicine and where people are with sickness and ill health. I've seen more trauma and more sort of mental ill health than ever in my career, and there are days that I think this thing's going in the wrong direction. Whatever we're doing from a urbanized sort of lifestyle is causing significant disease and sickness. So possibly maybe give a message of hope or anything you'd want the audience to hear.
I think the take-home message here from that perspective is try and look at what often helps you to simplify your life. Because the minute you try and perhaps adjust for what problems you seek, your outcome is never really going to be what you want it to be. So when you start struggling, take a step back and look at what has changed. Maybe that would be the first place to start. Because often we get into the cycle where we're desperate for some help, and the ability to think laterally and objectively is non-existent. So I share the same kind of frustration and concern as you do, because even at a subspecialist level, we are seeing a lot more of these individuals that we shouldn't really be seeing. And the simple reality here is we spend most of our time talking about the non-pharmacological management of a condition, right? And this is something that if you are aware of at the outset, typically, even if it doesn't protect you, it offers you some insight in terms of where you need to seek help, right? You've done sort of basic due diligence in terms of your nutrition or your sleep. You've quantified that, and you've now picked up that despite your best efforts, you have a problem. It certainly helps your practitioner because it helps guide the kind of directive testing and investigation you would need. As opposed to, I've been struggling with this for 5 years, I feel progressively worse and worse and worse. I'm desperate, I've been to 20 doctors, you are my last hope, fix me.
Yeah. And isn't that the common meme?
Yes.
Well, thank you so much for your calling, your courage,
Right.
who you are, the patients that you've seen, what you bring to health and wellness, and we're really going to try and push this podcast so more and more people can hear and actually help people from the ground root. I think if I look at sort of the grassroots levels and sort of just looking if we can get these lifestyle changes, these epigenetic factors in place, I think we're going to help a lot of people.
Yeah, I think we have to, because that's the only sustainable solution we're going to have in the near future.
Thank you. Thank you, Dr. Magan.
All right, thank you for the invitation.